Sorry.
All right, so we're going to start the meeting. We're here today for the Education, Environment, and Sustainability Committee meeting on Wednesday, March 30th. Madam Clerk, can you take the roll?
Calling the roll, Ms. Simon.
Here.
Ms. Brown.
Here.
Mr. Jones. Mr. Jones is absent at the moment. Mr. Shrine.
Here.
Mr. Brady. Mr. Brady is absent. There is a quorum.
Okay, I don't see a need at a committee level to excuse members on a committee. Okay, so is there public comment related to the agenda?
No, Madam Chair, no one is signed in.
Thank you. And we have minutes from March 16th. This involved the College Now discussion. Can I have a motion to approve the minutes?
So move.
Second. All in favor? Aye. Minutes approved. And we have one item today referred to committee. Madam Clerk, can you read 0068?
Resolution number 2016-0068, authorizing an, an agreement with Cuyahoga County District Board of Health in the amount not to exceed $914,124 for the newborn home visiting program for the Invest in Children program for the period 1/1/2016 through 12/31/2017.
Thank you very much. And we already have at the podium the director, Rebecca Darman. Hello.
Mic. And do you turn on the PowerPoint? Yeah. Here we go. So, and there we go. So this is our Welcome Home program, one of the most beloved programs, I have to say, of Invest in Children. The program goals are, as you see, to identify and address potential medical, mental health, or social concerns in both baby and mom. Provide education on newborn and postpartum care, and because this is a one-time registered nurse home visit in the postpartum period, perinatal period, it's meant to be a window or a doorway to other services, either that Invest in Children provides or other community services that are out there. So the nurse then will make the connection if any of those needs that can't be met at that initial visit are apparent. So again, this has a history going back to the origins of Invest in Children. And you may remember that it was a universal program funded by the state. Everybody in the county who was a first-time mom was eligible to get the program. As I said, one of our most beloved programs. Unfortunately, in 2009, when the economy went south, one of the things the state decided to do was cut the program. I'm very proud our community decided to find local dollars, and we've preserved it. It's much smaller now, and it's focused on our highest risk families, our Medicaid population. And since 2010, in that reconfigured version of the program, the Board of Health has served as both our lead agency and the service provider for the program all in one, and it fits really well, obviously, with their public health mandate in the county. So the way that it works is we have child find folks who are, two child find specialists who are spend their time going into the rooms in our birthing hospitals where most Medicaid births occur, which is at UH and at Metro. They go into the rooms of moms who are in Medicaid and tell them about the program and ask them if they'd like to have a visit. About 95% or more of the moms will say yes. And then subsequent to that, the nurse will call to schedule the visit with the mom. There are, as you see, 5 nurses when we're fully staffed. I will say it's been a challenge to keep fully staffed, but when we're fully staffed, it's been 5 nurses. As I said, it's a gateway to other programs and services. You can see that in 2015, we served nearly 1,400 moms and babies. We certainly think it's a great program, but we always are concerned about, how do we improve it? There's always room for improvement. One of the things, as we looked at when we got our last evaluation results, that, Case Western does all our evaluation. The nurses you may know are trained to do copious notes. They document, they write wonderful narratives. So a lot of the data that was gathered was in narrative form, and it was really hard to be able to pull out some of the key issues we were looking at, like the referrals that were made and follow-up, et cetera. So we wanted to both respect the nurses' training, but also respect our need for better data. So we've created a new data system that is just about to be launched that gives some drop-down menus for specific data fields and still preserves the text fields if the nurses want to also write more for us. So we're excited about that. The evaluation findings have shown that health issues are identified, as you can see, in 3/4 of the visits. Some are on the milder end of the continuum. You'll hear a couple stories today from Terry Allen, our Board of Health commissioner and partner, but some are very significant issues as well. Home safety issues, so there's a whole review of, the nurses there looking at what home environment is this baby in, and will identify if there are concerns, and do education. So, of course, safe sleep is a big one. Is there a place for the baby? Is there a safe place for the baby to sleep? Is it a bare naked crib? As you may know, that is the recommendation now. And when one of my favorite stories is one of the nurses at one of the visits was educating mom and dad, and all of a sudden the dad got off and ran away while she was doing this visit in the house, and then she discovered he had gotten a pair of scissors and was cutting the bumper off the crib because he was so freaked out about the potential that could somehow suffocate his baby. So one of my favorite stories of a parent who took immediate action. Smoking certainly is an issue, and there'll be referral to smoking cessation, educating the mom about secondhand smoke, dangers from pets. I have to say, carbon monoxide monitors are a huge issue because most of our families don't have them, and there isn't a free resource right now as a way to get them. So that is one thing. Parents have reported that they've gained in knowledge in terms of caring for their newborn. And I have to say, I can remember back to being a new mom, I would have loved to have had a nurse come out and walked me through a few things. So I'd like to just make it very real and invite Terry Allen up and share some of a couple stories, quick stories, and then you're certainly ask us any questions. So.
Thank you, Rebecca, Madam Chair.
Good afternoon.
Terry Allen from the Cuyahoga County Health Department. I would be remiss if I didn't first acknowledge the real brains behind the work and the heart and soul of the work is our Deputy Director of Prevention and Wellness, Ramona Brazil, and the supervisor for the program, Debbie Horvath, that are both nurses, both very much involved in this work, and they see it as their life's work, working with families in the community. So I'm very proud to be able to work with them. So a couple stories, quick stories that I wanted to share that give you a sense of the experiences that the nurses have day to day in the community. So one story is of a public health nurse that visited a mom who was very distraught because her baby wasn't eating and was extraordinarily fussy. And so she'd taken the child to WIC and was very concerned because the child wasn't gaining weight. Upon examination, found that the nurse found that the baby had thrush that hadn't been diagnosed yet. The nurse called, made an appointment with the pediatrician immediately, and upon following up with the mom informed the nurse that the baby did in fact have thrush and began treatment that afternoon after she reached out to her, and they made the connection with the pediatrician. And within 12 hours, the child was again eating and was happy, which means the mom was probably eating and happy too. We also have another story about a nurse that received a referral for an 18-year-old mom who had recently aged out of the foster care system. When a home visit was conducted, the nurse found that the parents had only a mattress on the floor, in the apartment for them and the baby to sleep on with them on the mattress. There were plastic lawn furniture to sit on is all they had, and a baby swing in the home. The nurse built a rapport with the family, determined through an assessment that there were some postpartum depression concerns with the mother. The nurse connected the mother with a service agency to provide support and also delivered a pack and play to the home and set it up for the family. We, through a number of programs that we run through maternal and child health funding sources, distribute out 600 pack and plays to the community. Safe sleep is a huge issue, as Rebecca noted, and a concern that we have along with prematurity related to child fatalities, which of course is a big issue for the urban areas in Ohio. And so that's a great connection to be able to link programs together to leverage different programs to serve families. Upon following up with the family, the nurse learned that the mother was seeing a counselor regularly and was using the pack and play for her child, and she stated that things had gotten much better. So the sense for us is the connections through Invest in Children and the partnership with the agencies that we've developed is to be able to link people to the range of services available in the community, to families that often are dealing with a lot of compounding disadvantages. And we think that's been essential and is part of the whole spectrum of work that is going forward around trying to help these families and these children, and in the bigger context, preventing infant mortality and helping kids in their early years. I did want to address something Rebecca mentioned about the nurse and staffing, because I felt obligated. It has been a challenge. In a community where 1 in 5 jobs is a healthcare position here in Greater Cleveland, we are constantly dealing with challenges with recruitment and also with seasoned nurses that are recruited to the clinical environment in Greater Cleveland. We also know that the health plans also recruit, and in the context of the Affordable Care Act, there's been a lot more of a conversion of public health and medicine. So we have been looking to address our the level of the pay for the nurses in the field, and also going through a classification and compensation process to make sure that we're competitive. I don't know that we can compete with all the clinical systems here, but we can certainly get closer to try to prevent some of the turnover. So with that, thank you for your time.
Any questions from the committee? Okay, Ms. Brown.
Thank you, Madam Chair. You mentioned that there are 5 nurses at full staff when we have them. How long are visits, or are there a number of visits that you try to do per day? How does the scheduling work?
Do you want me to talk? Go ahead.
If it's please, Chair, we can invite either Ramona or Debbie, who can provide great detail, or both, it appears, to provide, if it's okay with you, to provide some details. They have intimate knowledge of the program, and I would defer.
Thank you for allowing us to speak. So in general, our nurses try to schedule 2 to 3 visits a day. It just depends on whether or not they have no-shows or the like. So in general, a pretty straightforward home visit would take about an hour. If it's a little bit more complicated because we start to run into issues or we start identifying problems, it could be about 2 hours.
With that, Dr. Darman stated that there will be some drop-down menus to assist with identifying maybe some more common health issues. I don't have the numbers in front of me, but as it pertains to, I think it was 76%, do we know of that percentage, how many of them are on the major end of the continuum, as in her words?
You know, I would probably, just from my guess, my background is actually as a labor and delivery nurse as well before I came to the county. In general, maybe 75% aren't going to be problematic if you catch it then. So even a baby who hasn't gained a lot of weight might not be an emergency, but if that continued for another week or 2, that could be a much more serious problem. So I would say the remainder of that, about 20 to 25%, can be pretty serious. So in that circumstance, I would say something like sometimes we might have a mom with a very high blood pressure or who's had a C-section and she has what we would think may be an infection. So something that is more critical. We've had babies with undiagnosed hernias. We've had times where we actually had to, where we suggested that they actually call 911, either based on the mom's condition or the baby's condition. So those are not as often, but in those cases they can be emergent.
And then the last question that I have, with the new data system that's going to come into place, you said the drop-down menus. Can you kind of touch on some of the things and areas what the drop-down menus will cover?
Sure. Well, and you can, because you helped a lot with the development. So I think what is really beneficial, and as Rebecca, we had many conversations about nurses and documentation and how we are trained. If it's not documented, it wasn't done. So nurses take a lot of notes. But what the system will do is really make sure that it's standardized. So some of the things might be that, like, for example, the mom that has high blood pressure, or the baby that has a temperature or not eating well, or we think may have thrush, which is a yeast infection on the tongue. So those types of things, it'll just make it more standardized. I don't know if you want to talk a little bit more about.
Well, because a lot of the things that, hello, thank you for letting me speak. A lot of the things Ramona was talking about, they were captured in the narrative form. So even just pulling data for invested children was really difficult because everyone could write it differently. And you're reading pages and pages of narrative just to try to pull different issues out. So now having these drop downs, they can just drop and click, and then they can spend even, more time educating the families, and it'll be easier for us to pull data to support everything that we're doing. So it's going to be
And even
very
on
helpful.
the outcome end, so not just in what we identified, but also in the resources we connect people with. So to make sure, right now we probably spend more time than what we would like to be able to show when we go and visit, when we identify, what resource did we identify to help them with it, what happened when, did they make the connection there, what's the result. So there's a lot that we do now manually, trying to read through those records to find out. And this new database will help us make sure that those things are more connected.
Okay, so the dollars that are associated with the resolution, are they admin, or they include administrative responsibilities, or just
There's-
programs and services?
There's some, but it's a small percentage. We actually use the bulk of any program like that is personnel costs. So that is the majority of what that is contained in there. And we try and actually all of our programs at the Board of Health to put as much of that support in actual program direct service staff. So the administrative end sometimes it's only if it is available at the end. So right now, I think we cover our nurses at about 95%. So there's some board investment in supporting their salaries. And then the rest is really in what we consider the bottom portion of the budget. So to help pay for, we provide every family with a bag. We've kind of had to change what the bag looks like, but it contains resources in it. One of the things that we found out, I actually used to directly supervise the program too, towards the beginning of when it was first brought to the Board of Health. We would go to a house and the family didn't have a thermometer. So here you are trying to teach a mom how to take a newborn's temperature if you think they have a fever, and then they didn't have a thermometer. So we would, then the value of that really, is lost then. And I would have people ask me, can I keep it? And so one of the things that we purchased were thermometers so we could give that to a mom if they didn't have one. So there's certain, we give them diapers. We also work with, the Layettes. Christ Child.
Christ Child.
So in the circumstance, like when we encounter, which is a very sad circumstance, when you encounter someone who doesn't not only have the very basics they need for their baby, but they don't have the very basics, period. That's a very difficult situation to be in. But one of the things that we do, because those partnerships are very important, is we work through Christ Child. They give us a certain number of layettes every month. And those have some very baby basics, some layettes, some blankets. And so we work with them to provide those to families who may not have the very basic needs that the baby might have.
if you'd like a breakdown of the budget, I'd be happy to provide that for the committee.
I think that the service that you're providing is awesome. You're clearly very knowledgeable and have a wealth of information to offer to the clients that will benefit from the services. It is my hope that the new data system will produce more efficient results. And maybe, I guess the final question would be, do you predict that it will allow you to serve more families in the future? And if so, what is that goal moving forward?
Well, our goal, we would like to reach at least 2,000 families a year. I do think that it'll help definitely in the efficiency because it'll help our nurses to be more mobile. So they won't have to come into the office necessarily to finish some of, the cycle of what they do with a case. It'll also help our child find specialists because currently they still operate on paper. They do a paper referral, they fax it, someone data enters it, then it's assigned. And in this system, the child find specialist will have tablets in the hospital. They'll be able to directly enter in the client's information. The supervisor, who is Debbie, would then be able to see that right away. We cut out the data entry time, and then that can be assigned. So I think that also helps because that's a shorter time frame, and in dealing with, I have a 1-year-old myself, but dealing with a new mom, especially when you go home, the quicker you can get to them, the better. So I do think that will help us be able to reach families quicker too.
Councilman Schron has a question, and my question at the end, and maybe Mr. Schron will ask it, I want to see how your program interplays with the executive's initiative to combat infant mortality. It seems like you've been on the front line of this for a long time, and it's an effective program, so I want to hear about that, but
Yeah,
Mr. Schron?
well, one was the duplication, as you and I
Okay.
you're on the same page always on this. It appears to be a duplication in some respects, but my other one was, Rebecca, on your slide, you had a series of items of concern, and one of them was sleep and sleeping conditions. I don't seem to be hearing a whole lot about sudden infant death syndrome in the media and things like that, but I don't know if that was priority based on problem, or you just happen to be a random list. Is that still the number? Is that still the highest issue? Because based
It's
on
not
your,
the highest issue. So when we look at infant mortality, it's number 3 as far as cause in our county. So number 1 is prematurity. Number 2 are birth defects. So not as much as you can do about birth defects other than hopefully quality clinical care at that point. But in number 3 is sleep related. So I know because we also, we have a nurse who oversees our child fatality review program for the county and produces the report for the county. And so we saw a drop in sleep-related deaths over the last few years, and I think last year was probably the first year where we saw a little bit of an uptick. So it's one of those things where we've seen significant declines since the whole Back to Sleep campaign started, about 50%. And declines in the number of deaths, but it's one of those things where it almost has to be a constant educational point, not only with new parents, but also caregivers, because unfortunately, sometimes we see that a death may not occur in that home, but in a caregiver's home or something like that. So we're addressing it through the pack and plays, making sure the baby has a safe sleep environment, as well as making sure evaluating that safe environment. I think parents have heard a lot of the messages, and if they're asked in the hospital, they may say, number 1, they're concerned, don't take my baby away if I tell you they don't have a safe place to sleep. But also, it's something about seeing it that's different than being told it. So, that you go and you see the crib or you see where they sleep and you still see the, the bumper pads or the pillows or teddy bears. Recently, with the popularity of the boppy pillows, which are these pillows where you can use them for feeding and to prop the baby up when they're a little older, we've actually seen some deaths from those. So it's a constant educational point in that regard.
okay, I saw it was on your list. It was the first one you listed, so I just didn't know whether it transcended into that, and because the media doesn't seem to be as hot of a conversation as it was 3, 4, 5 years ago.
Yeah, I would agree. I've called it the low-hanging fruit of infant mortality, the sleep, because you would think that, prematurity is, medical systems, and there are a lot of factors related to that, we're still trying to sort out. So I keep thinking that if we can just crack the safe sleep issue, it's very significant. I think 16 babies last year. Is that about 16 babies last year? I mean, that's 100% preventable. That's not SIDS, what you're thinking of. I think and I think some of what we used to call SIDS,
Right.
now we realize it was the sleep environment for the baby. It wasn't necessarily something that it was inherent in the infant.
Yeah, all three of our boys
yeah.
survived, and we did
Of
just the
course.
opposite of what they're telling you to do today.
Me too.
100%.
Me too. I now
We put
look
them
at
all on
my
their back, and
child's
now
crib.
today
It
it's
was
all
like
they're all
a
on
death
their
trap.
front. Right, right,
I look
right.
at all the stuff we had in. I said it was a death trap.
We had toys and things and bumper pads and everything.
I loved it.
Yeah.
It would have been really hard for me to put my baby in a bare naked crib. Absolutely. But on a serious note, I did want to mention that Mary Louise Madigan used to be the county point person with the Child Fatality Review Committee, working with the Board of Health, which is the recipient of funding. That has changed as of a couple weeks ago. So Invest in Children is now going to be taking on that role with the Child Fatality, and we look forward to partnering with the Board of Health. And I think, safe sleep issues have always been a big issue for that group. But I think we'll be taking a fresh look at it. And we have this other partnership, so it works nicely together. I know your last question was about first-year Cleveland, and I'm going to hand it over to Terry.
No, that wasn't my last question. That was a question
Oh.
we'll get to.
Okay. Next question.
No, it was just more of a,
Yeah.
your comments were number 1 and 2 that are underweight and premature. I mean, those seem to be, at least from my reading of the research, a direct correlation back to your cigarette smoking, which is an item which I'm passionately against, and then the others probably not taking care of alcohol and things like that, or the whole thing with the nutrition and bad eating, bad smoking, all those kind of things. That
No,
out there.
I mean, honestly, having a healthy baby starts long before the mom's pregnant,
Right.
is what we know. We really have to, that's why we're trying to work on it, obviously, from birth. The babies of today are the mothers of tomorrow. And, the babies that were born that are the first Invest in Children babies, actually 16 years ago, are, starting to be of childbearing age. So, yeah.
But once the baby's born, it sounds as though the sleep is still the number 1 item, if you take out the fact that the premature, you can't do anything at that point.
Yes,
Yeah,
right.
those 2 points are already.
Correct.
That die is already cast once the baby
Exactly.
is born.
That's why I mean, it's probably the wrong way to carry the low hanging, but it's the one that
Yeah.
is, I think we all feel we just can't, we can do something to prevent it's just so unnecessary.
Okay, now the elephant in the room.
Okay, I'm passing the baton to my
Oh.
I will do my best to answer your question along those lines. Since 2013, we've been involved with an initiative statewide called the Ohio Equity Institute. That is health departments, in this case, coordinating with the Cleveland Department of Public Health and the Cuyahoga County Board of Health, working together with community partners in I think there are 8 urban areas statewide that account for 95% of all the African-American births and about 40% of the white births in the state. And the effort is to decrease the gap between black and white infant mortality that is about 2.5 times higher among African-American infants than white infants. And that has been a big gap that has been stubborn and in place for many decades, that we now, the commitment statewide and the State Health Improvement Plan is to address. So there's a consortium of 60 agencies that have been working on this. What I think is important about the First Year Cleveland initiative and the partnership between the county executive, the mayor, and the council president is now to see what we can do to to scale a number of things that we've been doing and provide additional resources to begin to turn a corner and commit. We have an agency strategic priority to reduce that gap between black and white infant mortality and our 5-year strategic plan that we just we just minted. And so it's important to us as an agency. And we see the natural consortium of the 60 agencies from the Equity Institute tying in and being the consortium for First Year Cleveland. So the way I think about this work is that you think about upstream things we can do, and then there are downstream or midstream type things we can do to try and deal with the issue. So from the upstream end, we received a $5 million grant from Health and Human Services at the federal level for teen pregnancy prevention, working in the first ring and in the school systems. That's teen pregnancy precipitates many other challenges. If you have a teen birth, that child is more likely to have a teen birth. There are more likely to be multiple teen births. The child is more likely to be on public assistance. The mom is less likely to graduate from high school. There are a number of sort of precipitants from that process that have impact on the family and the mom's ability to reach full potential and on the family into the future. So we do that work. We also have been working with the Center for Community Solutions and with the Gun Foundation and a number of other community partners. And certainly it's important to work with Rebecca and Invest in Children is the work around long-acting reversible contraception. Opportunities to provide availability of contraception more widely. We know that things like IUDs, for instance, are very effective, but the utilization is much lower than what it could be, and we know that's an effective preventive mechanism to unintended births. And so those are two pieces that are tied on the upstream end. As we think about the things that First Year Cleveland is looking at now into mid to downstream, is there's efforts connecting with the clinical care system around 17 progesterone treatment, which is provided. This is where these ladies can dive in deep, but I'll give you the surface. Is treatment during gestation that can help to prevent preterm birth, which then allows the baby to gain more weight. That deals with to some extent, help to assist with the prematurity issue. There's a program called Centering Pregnancy where high-risk moms actually go through gestation together. There's a support group to basically, there are classes that are coordinated through the clinical environment. Now the Federal Qualified Health Centers are working on the Centering Pregnancy program to then try to provide those support mechanisms for mom. And then we're now seeing in some of these classes that the moms are actually there at birth for their friends that they've met. They're there to be supports for the families and even after birth. And we're seeing lower rates of low birth weight as a result of these Centering Pregnancy programs. So that's an exciting development. There are efforts now around looking at doulas, basically, and this is, Rebecca could talk about doulas for probably till the cows come home about the work around doulas and support mechanisms for families and during birth and preterm. And so what I see in this effort, recently I would also say we met with the ministers who we've developed some new connections, ministers in the community, to think about the community engagement issues. And there are stressors also stressors of living in poverty and the compounding disadvantages of poverty that have a lot to do with healthy births and risks at birth and preterm birth. And so it's important to begin to connect on the engagement end, and the churches can also help us with distribution of pack and plays to high-risk moms, and the ministers were very excited about that opportunity. So we see First Year Cleveland as a way to try to create a sort of a community roadmap so everybody's everyone's singing off the same sheet of music. We're moving together, and we aren't in a situation where we have people well-intended moving in parallel paths but not working together. And it is my hope that through our process, connecting in, that we're going to be able to reach this goal to close a gap that has not closed for decades. So that's the picture now where we are with First Year Cleveland. And our involvement, I am not on the First Year Cleveland board. Right now, the First Year Cleveland group that initiated the covenant is the hospital systems, the foundations, and the elected officials.
Okay, thank you. But the question is, this council budgeted, I think, how much, $1.5 million for this infant mortality initiative. And this money did not go to Invest in Children. Did you get any money?
No.
So it went to someplace else that is doing work other than that which you have been doing together since 1999? Or have you been a partner that long, or is this new?
2010 on this,
2010 on
this.
this, but
yeah.
But have you had other programs together?
teen pregnancy prevention programs
Okay.
we've had other programs, yes.
Right. So you've been, as
Led-
my
led
short
was-
life on this charter government, I recall that Invest in Children and our Department of Health has been behind these initiatives, at least the broader visiting nurse and teen pregnancy. And now all of a sudden, the money that we allocated is going to this other place, other than where you've had a track record of doing really good work. I know, I don't expect a response. It's rhetorical.
It's a frustrator.
So this money is going specifically where?
I don't think we don't know yet. I mean, that's the truth. I don't know.
All right, I thank you. I just want to, I know that the track record and it has been, this is the one place in the county where we've had the objective overview of CWRU, right? Case has been tracking objectively the work and the stats and the outcomes in one place at the county now, where if the money were spent here, perhaps these programs could have grown and gotten back into the teen pregnancy and maybe pay some more nurses and broaden the program.
And it's only logical that there's another administrative cost that's gonna go on top of that 1.5 million, which is already in your system. It's already in your program. It's already here. So the deliverable would have, it just appears to me, I think to my colleague, that $1.5 million would have gone a lot further. But anyway, enough said on that. I guess it is, we're dancing to the same music together with you folks.
And in the future, I'd really, I think there might, is that the nonprofit board? Are they doing that one there too? Or is that just for the pre-K? I think there's some, forget it. Yeah.
We're letting our bias come out.
Well, it's not I mean, it's just the fact
Bias
that
towards a good program.
here's a good program that's in place and already have an infrastructure. And
Well, we're hoping that somehow through First Year Cleveland, we can expand, maybe more resources become available. We're waiting to see how it all, plays out. We're
it's
obviously
wasting
willing
time too.
partners.
It's really just wasting time. So not you, but this, creating this whole new mechanism or body. So.
Doesn't relate to this piece of
It,
legislation.
well,
A little bit.
well, a little bit, because this newborn program goes directly into preventing infant mortality, right? I mean, this would impact, if we had more nurses and more resources to put into this place, we could at least address the low-hanging fruit, as you described, the sleep issue, and knock that out as much as we can, and then focus on the teen pregnancy and the health and nutrition and the other two aspects. That,
Why a lot of packet plates for.
yeah, exactly. Wow. Okay, well, thank you so much. And so this is, the period of the contract has already begun. So is
There are
that,
reasons for that.
okay,
but
what do
do
you,
you want to know?
Sure.
I said it just in case. I know it got bogged down in the law department for just a little bit, and then the Board of Health has a new process. So, Terry has a board who governs the Board of Health, obviously, and they've switched to one monthly meeting where they approve it so he can sign it now. So that just added in some more time for the first time. So to the extent that it's possible to get this passed on second reading, it would be wonderful if that's possible.
Madam Chair, then I move that this be voted to the full council for second reading suspension.
Okay, all in favor? Aye.
Aye.
Any opposed? So this passes to the next council meeting under suspension.
Thank you so much.
Thank
And
you.
Thank you for your questions. We actually enjoy getting questions because it shows how much you care. So thanks. We appreciate it.
Thank you. And I want to thank Councilwoman Brown for chairing the meeting last meeting. I couldn't make it, but I heard there was an update on the pre-K and how that's going. So we'll keep you in the loop on that. I want to hear how that's going. Thank you so much. All right, miscellaneous business. We're going to meet in April. We're going to hear from the sewer district on some environmental initiatives and from the planning commission. Is there public comment, Madam Chair?
No, Madam Chair, no one has
Okay.
signed in.
Our meeting's adjourned. Thank you.